Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
The guest on this podcast episode has no disclosures to declare.
Hello, and welcome to JCO Article Insights. I'm your host, Rohit Singh. Today I will provide a summary of a phase 3 randomized study of Atezolizumab plus Bevacizumab and chemotherapy compared to chemotherapy alone in patients with EGFR or ALK-mutated non-small cell lung cancer. It's also called ATLAS study by Dr. Park and colleagues from Seoul, Korea. The purpose of this study was to evaluate the efficacy and safety of the ABCP regimen based on IMPAR-150 in patients with EGFR or ALK-mutated non-small cell who had progressed on prior targeted treatment. I will also discuss an oncology grand round case titled Management of Treatment Resistance in Patients with Advanced EGFR Lung Cancer, Personalization, Parsimony, and Partnership by Dr. Valilo and colleagues from Leahy Hospital and Medical Center and Tufts University School of Medicine, Boston, Massachusetts. Oncology grand round case help us to give a clinical context to the clinical trial. While TKIs are the established standard of care for non-small cell lung cancer harboring driver mutations, most patients may develop resistance to these treatments. Immune checkpoint inhibitors, with or without chemo, have shown clinical benefits of immune checkpoint monotherapy in patients with EGFR-mutated non-small cell lung cancer. Consequently, platinum-based chemo is the standard of care for patients with EGFR TKI failure. This was a phase 3 multicenter open-label randomized trial conducted at 16 hospitals across the Republic of Korea. Patients diagnosed with stage 4 non-small cell lung cancer with sensitizing EGFR mutation or ALK translocation were included in the study. Patients were randomly assigned to the ABCP arm or chemo-only arm in 2-to-1 ratio. Eligible patients were stratified on the mutation type, EGFR mutation versus ALK translocation, and the presence of brain metastasis. No crossover to atezolizumab was permitted. The recruitment with T790M mutation was capped at 30%. The patient who had responded continued to receive maintenance therapy with atezolizumab until disease progression or unacceptable toxicities occurred. If the patient was identified to have an acquired T790M mutation after the failure of a first or second generation EGFR TKI, the patient had to be treated with a third generation EGFR TKI before enrollment. The primary endpoint was investigator-assessed objective response rate according to RECIST criteria. The secondary endpoints included overall survival and progression-free survival at 1 and 2 years, and the duration of response along with safety analysis. Investigators also did the exploratory biomarker analysis based on PD-L1 expression and correlation with the response. They also analyzed the distribution of tumor-infiltrated lymphocytes, and a cutoff 20% inflamed score was used to compare the two arms. Overall, they enrolled 228 patients, 154 in the ABCP arm and 74 in the chemo alone arm. Most patients were female at 56.1% and never smokers at 62.7%. Brain metastasis was present in 42.7% of patients. Most patients had previously failed EGFR TKI therapy. However, only 8% and 30% received third-generation TKI as first-line therapy in ABCP arm and chemo-only arm, respectively. Majority of the patients were EGFR at 90%. The median duration of follow-up for the study population was 26 months. The objective response rate in the ABCP arm was significantly higher at 69.5% compared to 42% in the chemotherapy alone arm. The median PFS was significantly longer in the ABCP arm at 8.48 months versus 5.6 months, and the duration of response was similar to around 7 months in both arms. The median overall survival was also similar, around 20 months in both the arms, with a hazard ratio of 1.01. In the subgroup of patients with brain metastasis at the time of study enrollment, PFS was significantly longer in the ABCP arm at 8.4 months compared to 4.4 months in the chemo-only arm. In contrast, no difference in PFS was observed in the subgroup without brain metastasis. Regarding EGFR mutation status, there was no difference in the PFS or OS between the two arms in the EGFR deletion 19 subgroup. However, favorable PFS was observed in the EGFR L858R subgroup. For those with acquired EGFR T790M mutation, there was no difference in the PFS between groups, whereas favorable PFS was observed in the subgroup without EGFR T790M mutation. In the exploratory biomarker analysis, interestingly, the impact on PFS was correlated with the PD-L1 expression. The study found that higher the PD-L1 expression, there was better PFS. In patients with PD-L1 expression more than 50%, the hazard ratio was 0.24 for PFS. This is an interesting observation, as in previous studies, we have seen that PD-L1 expression does not have a strong association with response to checkpoint inhibitors in patients with driver mutations. Based on the distribution density of TILs in the tumor bed, the inflamed score was calculated using artificial intelligence. For patients with 20% of the inflamed score, the ABCP arm has significantly prolonged PFS at 12.9 months compared to 4.8 months. The median number of ABCP treatment cycle was 4, with 12 for Atezo and 8 for Bevacizumab as maintenance therapy. Pemetrexed maintenance was administered for a median of 10 cycles. Incidence of grade 3 or higher side effects was 35.1% in the ABCP arm compared to 15% in the chemo alone arm. Peripheral neuropathy, alopecia, and myalgia were the most prevalent side effects. Notably, 54% of the patients in the ABCP arm required treatment interruption or dose modification, and there were 3 reported deaths in the ABCP arm, 2 owing to pneumonia and 1 to cerebral embolic infarction. And around 10 patients, or 13.5%, patients in the chemo alone arm required dose interruption or modification. In conclusion, patients with EGFR-mutated translocated non-small cell who had failed prior TKI, ABCP regimen showed a statistically significant prolongation PFS and response rate compared to chemo alone. The patient in the subgroup with EGFR L858R without acquired T790 mutation and presence of brain mets showed more benefit. There was no difference in overall survival, though we need more mature data. Adverse events were higher in the ABCP arm. Interestingly, in the exploratory analysis, a high PD-L1 and inflamed score of more than 20% showed PFS benefits. Though we need to take in consideration that this trial was done and all the patients were recruited from a single country considering Asian ethnicity. And the most importantly, majority of the patients were treated first and second generation TKI, whereas third generation TKI is the standard of care in the United States. Coming to the oncology grand round, in this case, we'll discuss the management of treatment resistance in patients with advanced EGFR-mutated lung cancer. A patient with a 20-year history of tobacco use presents with weight loss and hip pain, found to have a lung mass, skeletal mets, and brain mets, and was diagnosed with lung adenocarcinoma. The patient undergoes palliative radiotherapy for brain mets. Comprehensive tumor Merkel profiling demonstrated an EGFR mutation exon 19 and alteration p53. Patient was started on third-generation EGFR TKI osimertinib. However, after 17 months, patient has symptomatic disease progression. Usually approach, if feasible, rebiopsy at the time of progression to evaluate for possible new mutation, which can guide further treatment options. As mentioned this earlier in the trial, acquired resistance to the TKIs is inevitable and heterogeneous. There are various mechanisms which have been proposed regarding resistance, including a second site EGFR alteration, upregulation of a bypass pathway, histological transformation to small cell histology, or suboptimal drug penetration. There are various approaches after disease progression on EGFR TKI. Combining EGFR-directed therapies to address resistance is an option. Primary results from Mariposa 2 study showed amivantamab plus chemo with or without lazertinib in EGFR-mutated non-small cell after disease progression showed a better objective response rate at 64% compared to 36% in the chemo alone arm. It also showed improved PFS with a median of 6.3 compared to 4.2 in the chemo alone arm. Combining immune checkpoint inhibitors, EGFR-mutated non-small cell, ICAs have been disappointing in advanced EGFR-mutated non-small cell, and combination therapy strategies are needed to improve outcomes. Studies, as I discussed, ATLAS have shown that combining a VEGF inhibitor with ICIs and chemotherapy can lead to better objective response rate and PFS. However, further clinical trials are needed to figure out the better subgroup of patients who can benefit from this combination. Should the TKI be continued beyond progression in EGFR-mutated advanced small cell lung cancer? Continuing the primary EGFR TKI, treatment beyond progression, may be considered for patients with indolent or asymptomatic progression or a localized progression. We can consider radiation, surgery, or ablation. This approach will potentially delay the need to change systemic therapy in patient. However, for patients with multifocal disease, progression requiring a change systemic therapy may be more beneficial to switch to next line systemic therapy options like platinum doublet with or without immunotherapy and VEGF inhibitors. In the case presented, the decision was made to continue osimertinib along with platinum doublet, deferring the addition of immunotherapy and VEGF inhibitor. This choice was based on factors like the patient history of brain metastasis and intracranial control. There is also high risk of toxicity, especially pneumonitis, with immune checkpoint inhibitors after using a target therapy. The patient showed clinical and radiographic improvement while on this treatment regimen. The decision to continue or change therapy at cancer progression is based on factors like drug tolerability, patient preferences, and specific subgroup with different outcomes, such as those with brain metastasis or specific EGFR mutation subtypes. Choosing between combination therapy strategies at cancer progression involve personalized decision-making to optimize treatment outcomes. Ultimately, the approach to management should be tailored to individual patient needs, preferences, and eligibility for different treatment modalities. This is Rohit saying, thank you for listening to JCO Article Insights. Don't forget to give us a rating or review, and be sure to subscribe so you never miss an episode. You will find all the ASCO shows at asco.org/podcast. Thank you.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.